Hi, welcome to our first for Accora. So it's Ask Accora Anything, and we have some of our in-house experts here. So I maybe I'm an expert, maybe not, but we definitely have three more here. So we have Jane, Sarah and Chris. But first I just want to introduce myself. I am Nicola, I am an occupational therapist, and I've been working for Accora here for actually 1 year today, so 1 year anniversary today.
Is it today?
Yay! Congratulations.
I made it the year. But yes, I suppose I really enjoy working for Accora, but I suppose my experience previous to Accora, I've been working out in the community, have experience within the acute settings, and just different specialties. I'll hand over to Jane to introduce herself.
Thanks, Nicola. My name's Jane Brewer. I'm an occupational therapist. I've been here nearly 3 years, so a bit longer than Nicola. My background has been mainly as a community occupational therapist in Hertfordshire and Bedfordshire. I also have worked with an equipment provider in the community equipment stores, and then I came to join Accora, and I really enjoy going around the country. I probably met some of you that are online at the moment, doing some training around the clinical benefits of our products.
My name is Sarah Thompson. I'm a tissue viability nurse, and my background is in the acute sector, in the community. Done a little bit of private work with a wound care company, and then I've been here now 3.5 years and absolutely love it. Same with Jane, going around the country, delivering education, support and everything that we can do for your service users and for yourselves as well.
Good. Lovely. Hi, I'm Chris. If you are based in the southeast, potentially you may have had to suffer me once or twice. So I started out for 4 years as a product specialist. So I was the one bringing the chair in with the occupational therapist and supporting with the assessments. In recent years, last 2 years, I've been an account manager, so helping with training, and yeah, I love it.
Brilliant, thank you for being here. So just a few house rules just to get kicking off. We have definitely been sent in some questions for this session, but if anyone has any questions that they would like, it's going to be very interactive, so please just pop them into the chat and then we can address them throughout the session. And then secondly, just everyone making sure that they have their mic on. That'd be really helpful, just to make sure there's no background noise. And then let's kick it off. So as I say, we've had some questions come in, so we'll run through those first, and they will answer other questions as they come through. So a few questions that we've had come in, and one of them straight off, maybe who's best to answer this? So do we offer joint visits or joint assessments to help choose the right product?
Do you mean I'll take that one. So that's what I done when I was a product specialist. The majority of the job is going out and doing visits. So a few different types of visits that we offer. We do like a full 1 hour assessment where we bring the chair to the environment, the care home, it may be the ward of the hospital, and just make sure it's fit for purpose and that it's okay for the OT, but most sports it's fit for purpose for the clients. And then we do revisits as well. So if someone has one of our chairs but their needs have changed, we can come back out free of charge and make some adjustments just to make sure it suits their needs.
Yeah, brilliant. Thank you, Chris.
We can also pop along as an extra clinician for you, maybe, can't we? Sometimes I know I've rocked up on a couple of visits and they just want another pair of eyes to look at that
From an
client,
occupational
your
therapist or tissue viability.
Tissue viability. You've done some really great stuff, haven't you, with pressure mapping and things like that?
Yeah, it brings a visual aid to the assessments, and it really shows what our service users are feeling and what they're kind of going through, but a visual aid to do that. So yeah, it's really handy.
Quite a holistic approach, then, isn't it? Getting
definitely.
everyone involved.
Yeah.
And Chris, I'm going to go to you again. What can you remember any standout maybe assessments that you've completed through your years in Accora?
Oh, I've got plenty. I think the one that sticks with me the most is it was my first assessment back after having my first child. So I'd done paternity leave and went back to this assessment, and it was quite a young dad, to be honest. He was like late 30s, he had a young family, and it was late stage motor neurones disease, which obviously, look, we see it a lot, it's super sad, but I don't know whether it's just because I got back off paternity leave. I brought the chair in and sort of set it up in the living room ready for the assessment, and I saw a picture on the wall. It was like him like strapping young dad holding his baby and his daughter. And when I spoke to the OT, she said the goal from the assessment is that he could be out of the bedroom and in the living room with his family, and he wanted to die with his daughter on his lap. and that really stuck with me and really was like a special moment. And I think in the end, the OT managed to facilitate that and get that across the line.
It's quite special, really, isn't it?
Yeah, that one really sticks with
And
me.
you're thinking about the quality of life of that person as they come through to the end of their life.
Yeah.
And making that meaningful those last few maybe days, weeks for that person. So the power of seating.
Yes.
Yeah. To allow that dad just to have those special moments come to the end. Really special one. Thanks, Chris. Another question come in. How do I choose the right mattress or cushion for someone at risk of pressure ulcers?
I get asked that a lot. There is lots and lots of things, well, not lots and lots of things you need to think about, but it is a holistic, looking at everything from a holistic point of view. We can send out some details following this webinar, but I always look at the Skin Preventative Care Bundle. So that is your surface, your skin, keep moving, incontinence, nutrition, and looking at all of those things and trying to get every single part of those at the best, the optimum. So for example, nutrition, if you've got someone who's malnourished, how can we increase that nourishment? How can we get every benefit to that person so they've got the oxygen going to the cells, the skin, the nutrients? You need all of that to keep your skin supple. So looking at all of those things, in particular is obviously nutrition, but keep moving as well. Movement.
If you don't use it, you lose it.
Exactly. And the amount of times I've been and seen a patient and they say to me, you know, I haven't had a pressure ulcer, and I almost want to say yet, because I've seen it so many times. You just have to create that environment, but ensure that people have the right advice and guidance as well, because you don't think something's going to happen to you until it happens.
Every time I'm with you, Sarah, I always learn something new, and I always every session that I always remember the session that you, I suppose, described the case, and the person was just spending a lot of time in the chair, but to encourage them to get up and move, maybe just moving their table a little bit further away, or their favourite item, just so they get up and actually take those few steps to offload as well.
Yeah,
And
just reaching over to get something and just take a little bit of weight off the bottom.
Even there's some really difficult cases out there, and one that sticks to my mind is, again, it's a younger chap with motor neuron disease, and he was sat out from 9 o'clock up until 9 o'clock at night and didn't move at all, hardly used the tilting space, did have a cushionaire, so had a really good cushion, but we were trying to look at different things that we could put in place. So I went out, did some mapping. He could then visually see what he was actually doing to himself, and we showed him different positions in the chair. In the bed, he had a tilting device, he had an alternating mattress. Actually, sleeping wise, he was okay, but we changed small things, but it was all these small things that will keep his skin intact for much longer to come.
And then sometimes as well, it's just about actually opening up the eyes of the user as well, and highlighting those different areas. So
you don't know what you don't
understanding, isn't it? I always find that if people understand it, then they'll almost like adhere or comply with those suggestions, recommendations.
Sorry.
Go on.
I was going to say, it often comes with, when people say that they're uncomfortable, we'll see that uncomfortable in the mapping. We'll see those red areas. So when they can visualise this discomfort, it's quite reassuring. And then if you give them, you know, if you just open up the backrest or use the tilting space and that discomfort disappears, it's a really, really good visual aid to show people. And
everyone is, sorry, I'm going on now, but everyone is quite different, aren't they? So some people are quite visual, some people are quite practical, so it's about meeting everyone's need as well, and making sure everyone understands. But yes, next one then has come in from Lucy, and this question is, what are the key areas that OT should be assessing when completing seating assessments? Jane, I'll come to you.
I think with all assessments as OTs, we really home in on the person, don't we? We do our holistic assessment, but you know, we need to find out about our person and what they want to achieve through seating. You know, do they want to be obviously more comfortable, a bit more functional, and really looking at that person, looking at their diagnosis, looking at their prognosis so that we can sort of future-proof our provision. But then getting hands-on and doing that hands-on postural assessment. I think since we've been doing postural assessments at Accora, you get more hands-on, don't we? So really looking at the positions when they're both in lying and in sitting, that's really key, because we know how much gravity can have an effect on our posture. So if we can assess them in sitting and then take away the effects of gravity and assess them in lying, so looking at their posture and looking at that posture, is it fixed or is it correctable? So if it's something that's fixed, we've just got to accommodate that posture and stop that getting any worse. And if it's flexible, how can we correct that and get that person in much better alignment?
Yeah, brilliant.
So really assessing that person. And then looking at the environment then, isn't it? As OTs, that's what we do best. So looking at how that chair is compatible with any other transfer aids that are there.
I think as well, I might add to that is maybe the range of movement, making sure that they have that range of movement in the pelvis and in the lower limbs as well, to ensure that they can sit into a chair properly.
Yeah, we can achieve that position that we want to. And then Sarah's going to be nudging me and said we've got to assess people's pressure areas as well, haven't we? Look at that surface that person's, look at their skin integrity, you know, are they incontinent, because obviously that's going to have a massive impact on that surface of their skin.
Well, as you said from the beginning, it's about having that holistic approach, so not just focusing in on, for example, the range of movement, but it's about having that wider view about our patients.
And what do they want to achieve when they're sitting in the chair, you know, so hopefully we can get them nice and balanced and stable so that they've got their hands ready to do the functional tasks.
As Chris said earlier, what is the goal? What is that person's goal?
Yeah, definitely.
Getting their
what
needs
do they
met.
want to achieve, aren't they? You know, is it going to be a chair with a rise function that can make them easier to transfer and get out and toddle off into the kitchen?
Yeah,
and things
promoting
like that?
independence, right? Maintaining that independence. And next question then, how can you balance functional positioning with pressure care needs when they appear to be in conflict?
So
Sarah,
it's a
back
lot
to
of
you.
what we were just saying, what Jane was just saying. It is very difficult, and you're going to meet lots and lots of different service users that are going to have their own things, their own risks, their own environment that might or might not be challenging. But it is making sure you involve that service user.
Yeah.
Because if you don't involve them and you just say, oh, you need a mattress or you need a cushion, it's not holistic. But the more you involve somebody, I find the easier it is to interact with them, the easier it is that they will tell you more about what their needs are, how to function.
Buy into it.
Isn't it?
They've got to get ownership, haven't they?
Yeah.
I think sometimes we can take away people's independence by doing things for them. We need to encourage them to do a little bit more, be in charge of their own treatment.
Saying that, there's always going to be that kind of grey area. So for example, if someone does have a pressure ulcer on their sacrum, I would want them to offload as much as possible, because we want these areas healed as quickly as possible, because then we don't have additional problems moving forward. But at the same time, we need them to function. So sometimes a multidisciplinary group approach and make sure, because you'll think of different things to what you'll think of different things, and then as a TVN I will as well, and then bringing all that together,
the empathy working, isn't it?
with that service user. And
how can we position them in bed so they can still carry out the tasks that they want to do, you know, get that bed into that sort of chair position so that they can still
and at the same time think about healing a pressure ulcer or that prevention.
Brilliant. Would you believe we have another Sarah? But I think, Chris, this is going to come to you. It's a bit more product related. So how customizable are your products to meet individual needs? Sarah asks.
I'd say very. I mean, if you know the sort of Accora range, the chairs especially are called the Configurer Comfort, the Configurer Light 2, the Configurer Advanced, for example. So they're designed to be configurated. So they're all adjustable sort of for width, depth, popliteal height. So that's like getting the size of the chair right. But then there's a lot more that you can go into that with regards to pressure care and cushions, and then posture supports as well. So quite adjustable. That's like the that's quite adjustable as it is, but that's
Yeah.
like what comes as standard, you know, that's
Yeah.
like the basics. But we do a lot of like SMPs, like specially made parts for the chairs as well. No beer holders yet.
Yet.
For yet. little wine holder for you, Sarah. Yeah. But like if someone has, you know, an unusual presentation, or they have sort of some asymmetry we need to work with, that's something we can work with as well.
Yeah. Yeah, and that's definitely, as you say, if people do have that, they can always call into her and discuss that, because it's likely that we've come across similar situations before, right?
Yeah.
Yeah.
These challenges.
Mhm.
That's seating, but what about your beds, Chris? I'm going to test you now.
Oh, good. Beds. I mean, bed's a bed. You know, there isn't
Yeah.
too much that we can do adjustability, but the main thing is that there's different options with the bed. So there's different lifting ranges, so
Yeah.
from 7 centimeters up to 80 centimeters, and I think the biggest game changer for us was the junior kit, or the anti-entrapment kit.
Yeah.
I've got an interesting story. You know the safety sleeve on the junior kit, right? When the alert came out, and you know we had to sort of get rid of all of them gaps on the beds, it was really it was funny. We actually had a bit of a head start, because that safety sleeve that we've got was designed for. There was a gentleman in a care home. It was on a dementia ward.
Yeah.
I think we've all had those times.
Yeah.
You might have heard this story on your training.
Yeah, I do. I use this lyric a lot. And he would, when everyone went out to lunch, he would then climb underneath everyone's beds, and he would unhook all of the cables, because he was like an engineer.
Yeah.
He's like, so we actually designed that safety sleeve for
Wow.
that care home. But then it gets.
So that was the
pretty close to that.
SMP.
Yes, yeah, it was.
Yeah.
No,
Yeah.
at the time it was an SMP.
Now
it was
it's a
special-
standard product.
And now
Yeah.
it's standard, isn't it?
Yeah.
But then with the beds, like bed levers, side rails,
Extensions as well.
extensions, yeah.
Yeah.
So they're really customizable for someone's needs, but also their size as well. We do a floor bed 1 plus as well, which is like a mediatric size as well.
Okay.
So I think the main thing with beds is that there's options
Yeah.
with it. There's lots of different options that we can build into it.
Yeah, brilliant. Thank you. Next question. I think I'm going to come to you, Jane. What are the early indicators that someone's seating needs reviewing?
Needs
Or maybe
reviewing.
red flags?
Yes,
Would
I
you
think.
say?
I think again, it's as OTs, you tend to get a lot of information, gather information, don't you? So it's sort of unpicking that information to find out why someone chairs needs reviewing. Sometimes it can be that subjective information you get from the client, from carers. You know, they're saying they're not comfortable, maybe they're in pain. And then it's also looking at what you see objectively. So, you know, looking at their posture. Are they leaning to one side? Maybe are they sacredly sitting? So you can do what you hear and what you see will then lead you to work out what we need to do
Yeah.
to make the chair more comfortable for somebody. And it could be something that the chair's been set up at the wrong seat depth, couldn't it? And that could lead to somebody going into posterior pelvic tilt, and that's why they're feeling a little bit uncomfortable. Maybe that's putting pressure on their sacrum
Yeah.
and
Sliding
Yeah.
out
and they're
the chair,
sliding
yeah.
out of the
Yeah.
chair. So it's been a bit of an detective,
Detective.
really,
Yeah.
isn't it?
Problem solver.
Problem solving to find out
Yeah.
what's going on there. And again, looking, I think, as well at that person's whole day.
Yeah.
You know,
Yeah.
they're saying they're uncomfortable, but actually, how many hours are they sitting in that chair? You know, some
Yeah.
people they're sitting there from 9 o'clock in the morning till 5 o'clock at night.
Yeah.
And if I was to sit there all that time, I would get uncomfortable. I'm
sore
fidgeting
thumb.
around now, and
Yeah.
I've only been sat here for 20 minutes. So, yeah, can
Yeah.
they alter their position?
And then you have people, you know, sleeping in the riser recliner for 24 hours
yeah,
as well. So
exactly.
how can we
exactly.
optimise that position, isn't it?
Yeah, again, it's encouraging people to alter the positioning that they've got
Yeah.
in their chairs.
Yeah.
You know, can they recline the back a little bit? Can they
Yeah.
lift their legs up
Yeah.
to make them more comfortable? But yeah, there's 100 reasons, isn't there, really,
Yeah.
that once you start delving in, why a chair needs reviewing.
Yeah, for
Yeah.
sure. Thank you. I'm going to head away to the live questions now. We've had a good few come through. And first up is Nathan. So hi, Nathan. Sorry, Sarah, I'm going to come back to you. So can a Toto mattress be used with a floor bed?
Yes, I don't see why not. With a Toto mattress, so for those of you who don't know, it's a tilting mattress, and it's a platform that you would put underneath a mattress. So that's whether it's a foam alternating, you can put it under anything. You've got your own risk assessment that you need to do alongside that, so use of side rails as well. So you've got that thing to think about as well. However, there is absolutely no reason why you couldn't use it on was it the floor bed was the question?
Yes,
yeah, absolutely no reason why. But it's just taking into account those assessments that you would do as normal with a Toto. Yeah. And I think there's loads of different tilting devices out there now. And I think companies would have assessment forms or give you advice and guidance.
And I think about MHRA guidance that was brought out, that was updated because we were using a lot more tilting and turning devices, and then obviously there's a risk that people can be turned on to side rails, isn't there? So
just that people mitigating that risk.
Doing your risk assessment, definitely.
It's when you're utilising additional equipment with the equipment you've got, and mitigating those risks.
It's that compatibility, making sure that everything's compatible, isn't it?
Yeah. Brilliant. Jane, I'm coming to you because you've done so much amazing work with our Ascender product. Anita is again asking, I've heard about a new product called the Ascender. What kind of service user does it get used for, and can you do joint visits with it? Maybe. Do
you want to take first half and I'll take second?
Yeah, help each other out there.
So Nathan, I love the Ascender. These guys know it's been my little baby. So actually, we're marketing it as a riser bed.
Yes.
So really, if you think about, I guess you're an OT as well out there, and I know from when I was a community OT, the biggest problem was bed transfers for people. They just really can't. Lifting their legs is difficult, but also that lateral movement, getting their legs across onto the bed was really, really difficult. So with the Ascender, the person sits on the end of the bed as such, and then it sort of takes them into a tilt position and then lies them out flat. So it's really there for those people that are struggling with bed transfers. And can be used with those clients who are ending up sleeping in their chair because they can't manage bed transfers. So they're the sort of client group really that you'll be looking at. Mainly suitable for people that are still mobilising, so they've still got some weight bearing ability. What else was part of Nathan's question?
So I've heard about the new product called the Ascender. What kind of service user does it get used for, and can you do joint visits?
You can do joint visits.
So I suppose some of the
clinical trials, I'll just touch on those. So we've done some clinical trials, and it really worked with some Parkinson's people, most of all. Because they're very stiff in the mornings, and they struggle to get out of bed. So we've had quite a few people. We've had one lady whose husband was really, really manhandling her really into bed. It wasn't a great thing to see really, and he was really at risk of developing his own problems, his own back burnout. He was doing everything, getting up 4 or 5 times during the night to help toilet her. We took the Ascender out there on a trial, and she was able to operate that herself and transfer in and out of it herself. He had to be there because she had issues with balance and things like that, so he was still there, but all that physical manual handling he didn't have to do anymore, and that was really successful for him. But
for both of them as well, isn't it? It's not just her, it's him as well, so it's a whole.
I think they were looking to put in a package of care in for that one.
I was just about to say,
that's right. I think
cost effective, isn't it?
Offhand, I think it's about £322 a week. Because it was the fact that he would need 2 carers, because she didn't really have that much movement. So for manual handling purposes, we were looking at 2 carers, morning and evening. So you think of the cost savings there, and also for me, you can't really put caring in the night. That's non-existent now, isn't it? So then you'd having to think of another solution to manage her nighttime toileting needs, and so for her dignity, she could get out in the night and with her husband just being there. So.
And again, it's that quality of life, isn't it, to be independent to do that. Chris, you'll know this answer.
I'll take
the
this
cost. The cost maybe of that Ascender.
So it is. So most similar products are up at 10-12k. So sort of them sort of turning beds and that sort of equipment. We've put it in to bridge the gap so that after you've used leg lifters to get into bed, them sort of inflatable leg lifters, or if you've tried like a floor bed or a low bed, ultra low bed, if that's still not doing the trick, the gap is from £1,100-1,500 of a low bed all the way up to 10-12k. So the Ascender sort of fits in that gap nicely because it's 2,750.
And if you think back to the care cost as well, so we was, what did we say, £322 a week on average, you know, that's not going to be many weeks till you've...
A couple of months and it's paid for, isn't it?
Yeah.
Yeah,
But with assessments, Nicola, we do assess, like we do with the chairs and the beds. We can come out and do the full assessment or the revisit. Exactly the same for the Ascender. So we can bring the Ascender out to try it in the community or in the care home or the ward of the hospital. And then we can do revisits. So if someone's needs to change, we can change that as well. We've got 3, so the PS team for chairs is quite large. I think we've got about 18 product specialists. With Ascender, I think there's 4. So we've got Tennyson, who's the product lead with the Ascender, who's great. He's really passionate about it, isn't he? And in the south of the country, we've got Sean, who is an OT as well. And in the north, we've got Louise, who's great. She's an OT. She does them up there. And I think there's in the Midlands, we've got James. Does Ascender as well.
Brilliant.
So just contact us if you need an assessment, and we'll get one booked in, and then you can trial it. And if it goes really successful, I'd love to hear from you, because we can write some case studies about them as well. I like a good case study.
More to your baby, which is great.
I love a good case study.
Moving on then to say hi to Paul out there. What are the most common home environment challenges that end up undermining otherwise sound clinical reasoning? Jane, maybe you and I can battle that one out together.
So equipment.
So what are the most common home environment challenges that end up undermining otherwise sound clinical reasoning? So I suppose it comes to that environment, and how is that environment impacting our clinical reasoning, really, isn't it? How often, maybe me and you, Jane, or maybe people can put a thumbs up or hands up in the chat, how often have we gone into a lovely big open space, we have so much room to work with, and we can provide what is required for that patient? Probably very few of you.
For me, it's
how
always
often
that
have we gone into a
porch.
box size room?
For me, it's a porch. You know, when you open the door, you go on a visit, and they have a little porch, and then they have another step up, and then they struggle to get in, and then they got into the little porch area, then they've got to step up. I always struggled what to do with that.
I think one for me definitely is, you know, it might be, for example, with the Ascender, if someone needs that Ascender and they need to have that full extension of it to allow to meet that need, it might be the environment is just not allowing it. You can't, it doesn't give you that space because that person is in that microenvironment.
I think I've just been into a care home actually, and we assessed a lady for our advance. She was a lady that had been sitting in a wheelchair in her room in the care home. They didn't have any suitable seating for her, and she was hoisted. So we went in with the advance, but the care home room was so tiny. I actually gave them a powered chair. It was one of our reconditioned chairs, but we gave them because there wasn't much space for the carers to get behind to tilt the chair.
Brilliant example.
So we went for powered, and they could then alter the position of the chair. The lady actually was very cognitively intact, so I gave her the handset, and she was lovely. She was getting her legs up and everything. Just gave her so much more independence. Even though she was in the care home, she could operate the functions of the chair herself, and then we sorted out the problems with the lack of space as well.
We've so many examples. We could talk about it all day, right? Environment and how that impacts any equipment need. But I'm hoping that answered your question, Paul. I do want to encourage everyone to add in some questions if they have any more questions. But next we have, there's no name here, but would all your chairs fit through narrow cottage doors? Chris?
I'll take that one. Good. So it depends on the size.
I want to know where that cute little cottage is. The holiday in that cottage.
Are you thinking of like
you fit in with your height?
No, I know. Back my head. So with the riser recliners, absolutely, because they will come out in 2 parts. So you would be shocked the amount of calls or emails I've had from people saying it doesn't fit through the door because they're trying to deliver the chair, trying to get the chair in one part. This is for the riser recliners for the comfort, the like to bariatric, and so on and so forth. So how it would work is backrest comes in and you just walk that in on its own, and the width of the chair would take up the height of the doorway because you have the chair on its side. Does that make sense? I'm using my hands now, but when I'm explaining this to an OT over the phone, it's really hard. I do. I actually do as well. So that's how we would get any sort of rise liner in there. Now, if it's a tilt-in space chair or a chair that's on wheels, it's a different game because you can't take it apart. Actually, can I?
Yeah.
Can we go over to here? Because
I
this
think
might
it'd be
be.
great to just
Yeah.
demonstrate
That's a good
the
point.
It's not only just the width of the chair, is it? As well. We've got to think of turning spaces
Yes,
as
that's
well.
the most important part. We've got the configure advance here. So with this chair, the widest point of the chair is the backrest, just here. Now that is about 26.5 inches wide. Standard doorways are 29 inches wide. Them small cottage doorways, sometimes they can be sort of 27 inches wide. 27 inches wide, you will still get through here fine. The issue becomes when it's like the cottage doors that are like
Just mind your head.
yeah, this is
Yeah.
one of them, you know, low beams and everything. So the armrest, people say, oh, the armrests are going to get caught. That's not actually what's going to get caught, because this is the widest part of the chair. Unless the chair was set to 22 inches wide, that's when it wouldn't get through a doorway. But I have been known to, you know, take armrests off, take overlays off, take it down to its bare bones and get it in. You can also flap the backrest down as well. So that is something I've done before. So I'm pretty confident. I mean, look, I've been known. There was one OT in Essex. I think she's just back from maternity leave, actually. I need to reach out to her. Me and her were like carrying chairs over little fences like this, trying to get it in. So I'm pretty confident most houses in the UK, you would be able to get a chair in by hook or by crook. So.
And sometimes I know from my previous job in the equipment service, it was sometimes like we issued a chair on the provision that it was actually just going to stay in that room.
Yeah.
Because so we'd strip it all down, get it in, set it up for the service user, and then it remains in that room.
Yeah.
So, you know, if someone is just hoisted in a micro environment, it's still good to have a chair on wheels, isn't it? Because it makes that hoisting activity a lot easier when the chair's more portable.
Cuts down on transfers as well. So
Yeah.
the amount of times that when I was a product specialist, we would go and you've got micro downstairs living environment, you've got bed in one corner, rise recliner over here.
Yeah.
You'd do one transfer via hoist from bed to wheelback commode or wheelchair, bring them over, and then you're hoisting again.
Yeah.
So with a chair like this, you can bring it.
Just
Bring
create
it
to
in, and
them.
you've got that one
Yeah.
transfer.
Yeah, that's it.
Yeah. I always just think of my times as just working. I live and used to work in London as well, so it's not just small cottages. It's definitely small apartments too, and you have apartment on top of apartment, so you're going up small narrow staircases. But I used to ensure that when I was doing the prescription, that was very clear with my instructions and the comment of that order. So just giving that delivery person some clear instructions that what is required when they're delivering that chair.
Helps make it more successful delivery then.
Yes, so you don't have to keep going back and back. Next up then, so hi Justine, what should we prioritise when time is limited? Safety, function or comfort? Big questions
Great
here.
question.
Big question. I love that.
Great question.
Different answers.
So what should we prioritise when time is limited? Safety, function or comfort?
It's got to be safety.
Yeah, safety.
Yeah.
I think that you've got to go safety first, because we don't want to put any of our service users at
Yeah.
risk, do we?
And we have that duty of care as well.
yeah.
To
What's the last two?
Comfort.
Function and.
I think
Comfort.
personally, I go for comfort.
Oh,
Because if
Vegan
somebody's
I would go comfort.
because if somebody's not
They're not
comfortable,
gonna use
they're
it.
not going to want to sit in the
Yeah.
chair. They're not going to use
But
it.
if you can't drink your cup of tea, then you're not going to be comfortable. So you need to be functional.
But if
What
you're
do
not comfortable, are you going to drink a cup of tea?
Oh,
Where do you sit, Nicola? Are you going function and
I'm
comfort?
for the cup of tea
I'm,
and the
I'm
biscuit.
function.
But you'll be uncomfortable.
Yeah, be
Yeah.
fashion over function.
There's quite a lot of things if someone is uncomfortable, if they can't reposition or alter their position, they're
Yeah.
stuck in a place where they're
Yeah.
uncomfortable for
Yeah.
longer, they might adopt a different sort of posture,
Yeah.
and then you could then end up with sort of contractures and muscle shortening if they're sort of
Causing a
taking off that you get them knock-on effects.
Well, each one of them you could talk an hour on each topic. So
Yeah.
functional. So
Yeah.
as you say, you might be able to lean out and get your cup of tea, but can you actually get back into
into
that midline, that good
drink it.
posture?
Yeah. Or you're going on the way of
I'll be
comfort now.
spilling.
Who
I'll be
sent that
spilling.
question in? That's fantastic.
Justine, what would
Your-
you
your thoughts.
prioritise?
What would you go for? Yeah.
Or what would everyone prioritise?
Yeah. Well, I can feel a new webinar coming on.
Yeah.
Subject, yeah.
Oh, thank you for that. We'll have that one. Yeah.
Etty, you're up next. So hi, Etty. What questions do you think OTs should be asking that don't usually make it onto referral forms? Big questions coming out again.
These are great questions.
So what questions do you think OTs should be asking that don't usually make it onto referral forms?
Is goals one that is on?
Yeah.
I don't know because I don't see the referral forms. I've never been an OT, but is that one that's on there?
You should have like what you're when you're referring to a service, what do you want to achieve from that referral, shouldn't you? So sort of goals, but sometimes they're the goals of the clinician referring. Sometimes they might not have had that discussion with the actual patient about goals.
Yeah.
What other questions are on referral forms?
I mean, I think the goals one is quite an important one because you want to be person specific as well and meeting their overall need and again quality of life. I'm big on quality of life and making sure that someone is comfortable and happy as well. But let's. What questions do you think OTs should be asking that don't usually make it onto referral forms?
I think sometimes all the questions that are on a referral form, there's often an extra question that you have to ask. They put someone's weight, and then you need to think, is that weight stable? Have they put on weight? Have they lost weight? Mobility. They might put on a referral. If it's a tick box referral form, it might say mobile, but are they mobile with a
how
stick?
Often?
How often do
What's
they move?
the frequency?
So for every question on a referral form, there's something extra.
But then sometimes maybe it's not expanded where it needs to be expanded a little bit more. Maybe going back to that questioning around the environment and what does that actual environment look like when we're setting up that piece of equipment?
I think for me on that, and again, I've never been an OT and I don't know what your referrals look like, but I like to know the activities of daily living. That sounds like I don't want to know War and Peace. What I want to know is for your 24-hour clock, when you're getting up, what surface, what chair, what bed you're in, how long you're in that, and then all of that activity throughout that 24-hour period. Because that way I can visualise that service user, I can find out other bits of information, but I don't know if that would help on a from a pressure point of view.
I think you get that baseline information on a referral form, don't you? And then you ask a few more questions, like what does I always ask my patients, what does a typical day look like for them? Roughly what time do they get up, and then you can work through their day and you can find out sometimes other difficulties that they're having. They're just dropping, they don't see it as a difficult, but they're just when I'm putting my socks on it takes me ages, and you think, oh right, well you must have problems reaching down or something like that. So.
Is there any questions on that referral form regarding like the timeline? I know we touched on it, but the timeline of someone. So at the moment they are this weight, this size, this transfer method. What were they previously, and what do you imagine it will be going forward? Because that's some of the questions OTs would always ask me and say, look, to be honest, they are this weight, but they're on the way down or they're on the way up. But transfer as well. So everyone assumes it's like a steady decline, that they're transferring sit to stand at the moment, but pretty soon it'll be stand aid and eventually hoist. We don't ever look at the rehab potential.
Depends on your prognosis and
this is
diagnosis.
And it depends on where is that patient in their journey.
They may be hoisted at the moment, and you stand.
I love your passion here, Chris.
So, get into chairs. I love it.
I think from acute experience, you always, if someone has been admitted to hospital, they're going to have that baseline function. So what was their baseline function before they were admitted? So they might have been mobile, then they're acutely ill, they decondition as they're in hospital, they lose muscle mass, they lose their ability maybe to sit to stand. So as they're in hospital on that patient journey, hopefully they get lots of physio or OT input on the wards, and then when they go home, there should be that referral to that community services to I suppose to have that rehab as they move along.
Looking at whether you can then get them back up to that baseline level, isn't it? Because sometimes the condition that they now been diagnosed with, you're not going to get there, but you should always look at giving that person the most opportunities to get back there.
And I think that's when choosing the right product for your patient or client is most important, because for example, if you have someone who's maybe had a stroke and then they now are being hoisted, but we want to rehab them, we want to promote that independence, right? So maybe I'm going to just throw out a product, but the Solus, right?
Definitely.
That meets the functional
I think with the
changes.
Yeah, definitely. If you've got somebody who you don't want to take them off their feet, do you? So you don't want to put them in the chair where they're having to be hoisted and they can't do a standing transfer. Let's look at a chair where they can be hoisted into it, but then still practice their standing transfers.
I just had it. I was in a care home last week, and that's just same example.
Yeah.
So the client actually had a fall a couple of months ago. He had a period of time in hospital. Then he went back to the care home, and he was being hoisted by the nurses, because for the nurses it was the safest method, but the physio was coming in quite regularly practicing that sit to stand. So I actually issued the solace. So I was enabling safe transfer method with the carers, and then again allowing that person to have the opportunity to do that rehab, to promote that independence, to keep that function, keep the strength.
I think when I'm out
There's
doing,
my passion coming out.
I think that's when we're out doing training. I think that's sometimes the call for OTs out there. Do I go for a comfort when I know I can keep them weight bearing, they're still on their feet, but I know that they might be hoisted in the future. They might be hoisted. Do I go for hoisting now and things like that? So it's getting something in the middle, like the Solus, meets both those needs.
And pressure wise as well, if things deteriorate and you suddenly need any pressure surface changes, you can add that to the chairs.
Yeah, for sure. Another big one here for us, Jane.
These you testing us.
Maybe a new webinar coming up here again. So Aileen, sorry. As more complex patients are supported at home, how do you see the community role of the OT evolving?
Okay.
So as more complex patients are supported at home, how do you see the community OT role evolving?
I worked as a community OT for probably about 15 years, 20 years maybe, and even in that time the complexity of the patients that we were looking after really did change. And one area I worked in, we had that sort of hospital at home team, so we had a real good multidisciplinary team, so we had nurses, physios, all within our team, so we could provide that same level of care at home than what we did, what they had in the hospital. So I think it's that multidisciplinary working to help support these people at home.
I agree as well, and I think as well, as we have an ageing population, and I think posture management is definitely becoming a big topic at the moment.
And I think positioning as well.
Positioning,
a lot of people at home are being cared for in profiling beds because their conditions are more complex. So we've got to really be aware of how we're positioning people in bed and looking at that 24-hour picture as well. And if we're providing postural support in someone's chair when they're sitting out, we've got to replicate that in bed. We've got to replicate that in their shower chairs. If we know we're using tilting space in their say their advanced chair, we need to make sure their shower chair has got tilting space.
So again, it's looking at that 24-hour picture, and having that holistic approach. Maybe it's about getting other members of the MDT involved. So
and I think there's, and when you've got those complex people at home, it's having that sort of case management sort of service. That someone manages that case and make sure all the right clinicians are drawn in.
And I think as well, it just leans into the the goal of ORCOS, so the Royal College of Occupational Therapy. They're
we wouldn't have those complex decisions if we could get into that preventative work.
Early
intervention and preventative work. Probably people out there are shouting, we never get a chance to do any preventative work.
But again, that's it's quite a challenge, isn't it? Because every service, every area that people are working in, it really depends on the resource and what's available, and as well when it comes to equipment and what is available within each area.
So varied,
it can be quite challenging, can't it? But I suppose we just want to ensure to advocate for our patients and get the best in place.
Yeah, definitely.
Next up, Jane, maybe we'll move on from you for a second.
Have a break.
Are you ready, Sarah?
Oh dear.
Okay, Vaclav, hi. So, are your chairs compatible with specialised cushions like Vicare, etc.? Is there removable middle cushioning? Actually, maybe Chris. I was
going to say,
and side zipper to remove the cushion.
So, with cushions, as long as so we have an Accora that Chris is going to show you. That is, tell me if I'm right or wrong, Chris.
17.5.
17.5 by 17.5 by 3 inches. As long as your cushion is that size, and the 3 is quite important, because you don't want anything higher or lower, because you will potentially increase the pressure, because somebody will be sitting on that. It will increase the pressure in that area, so it needs to be that 3 inches. But effectively, you can use any cushion that fits into that space, as long as you have the thought process of why you're choosing that cushion. So so love the ViaCare cushion, because you can adapt it for your service user, and you can offload areas that you might need to. And I don't know off the top of my head what dimensions are, but I know in Ireland they use ViaCare quite a lot, so I think it must fit in.
I would say I would add on to that, because that I'm not sure if you're more concerned maybe about the pressure needs or the posture needs. So it might be that you're using for pressure care needs, but then we need to really think about that pelvis. Remember, the pelvis is the foundation of good posture. I don't know what I'm doing.
It's a little bit of both.
So we need to have a stable pelvis. So if we instabilize the pelvis, then that could actually lead to pressure sores. So it's about getting that balance. Thank you. And today's top news.
But like ViaCare, the ViaCare cushion's really good if you've got somebody who's got a fixed pelvic obliquity, so that they're dropping down in the pelvis. You can take some of those air sacs out.
Yes, thank you for adding that one
to sort of drop that pelvis down so that it's more immersed into the cushion. Equally, you can, if they've got a flexible pelvis and you want to get it nice and level, we can have a bit more stuffing under that side of the pelvis to sort of level up the pelvis.
Yeah, for sure, definitely. We do have one more question, but if anyone else has any questions, please do pop them in the chat before we say goodbye. From David. So hi, David. So question, if you could change one thing about community equipment provision tomorrow, what would it be?
Can I answer that as well?
Yes, go ahead.
Yeah, if it's burning now, get it out.
Just from my point of view, I've got a big thing about edematous legs, and I think it's all about prevention with edematous legs as well. And I think, certainly from what I've heard, providing a chair doesn't kind of come under that. Am I right in saying that? So you can't provide a chair.
It varies in some areas,
So from my point of view, when you get edematous legs, that is a spiral kind of add-on effect. So if your legs get swollen, they get heavier. If your legs are heavier, your mobility decreases. Your mobility decreases, you become more at risk of pressure ulcers. So it's this spiral that starts with edematous legs, and actually I'm doing a webinar on this in March. So it's a big thing for me, although we don't necessarily look at the legs kind of straight off. It's one of those things that we pick up much later on if they become ulcerated. So for me, if somebody's got ulcerated legs or edematous legs, I would want them to have some kind of seating. I'd obviously want them to go to bed at night, but I'd want some seating where you could elevate the legs like you can with our Tilton space and things. So from my point of view, if that's the only thing that they've got, I would like that provision that we could have that for the legs, because it is a big thing. It's a knock-on effect.
It's a vicious cycle, isn't it?
I think generally equipment provision, for me, it would be to have consistency. I think where you sometimes only work in like one area of the country, you get used to what is provided in that area. But when you go out across the country, you start to realise, that one area will provide seating and one area won't. And
consistency.
Someone does bathing products, someone else doesn't.
Postcode lottery sometimes.
And it's if we could make it a nice equal level playing field for everybody, I think that would be good.
I might go in a bit controversial as well and say, not to be over prescribing. We want to promote independence. We want to enable people to get back up, and if they're being discharged from hospital, we want them to achieve those goals.
And for me, and I always think as well with when I used to do training in my other job, it would be to review the equipment that you prescribe, because if you don't review that piece of equipment, you might as well not have given it in the first place, because a lot of people have to adapt the way they do things when they get a new piece of equipment. So, we need to make sure that they're carrying out tasks in a different way to make that equipment better for
Yeah.
them.
For sure.
I kind of think, how many bath boards did you give out?
Oh,
And then never
Yeah.
followed up. Then that person could now reach their shower gel or their loofah and things like
and
that.
I suppose it always just comes back down to, again, resources within the area as
Yeah.
well. So we try to do our very best when you're out there too, isn't it? So.
Yeah.
But for me, again, I'm going to go back to it all comes back to that quality of life for that patient as well,
Yeah.
and making sure that they have good support systems and a good setup at home. That is concluding our questions in the chat. But if anyone does have any burning questions, please feel free to drop us an email. We'd be more than happy to follow up. And we do hope you have enjoyed this session. It's a first for Accora. And I hope you enjoyed our experts' answers. And we would love to get some feedback from this session. It's something, as I say, new. So if it's something that you really enjoyed and you'd like to see again, please let us know. But yeah, for now, thank you so much, and we hope to see you all again soon.
Thanks, everybody.
Bye-bye.
Thank you.
Bye bye.